one CE we've already talked about over the last couple months, such as abuse and some of the other things. So even though I can talk for hours usually on something, I have a hard time getting through 2 hours with it. So we'll be in and out of here pretty quick. Brian, yeah, no problem. Brian Melville is the Director of Education for Superior Ambulance. He put this in here. One other thing I kind of want to let you guys a little heads up. Starting in, I think it'll be February CE this year, we're going to do one CE on all of the new information that you guys technically need to know for the new education standards. Yeah, don't get too excited. A lot of the stuff you guys are not going to do, but we have to at least tell you about it so we can write to the state and says, yep, they've all been updated with the new education standards. So we're going to just try and knock all that information out in 1 month. There is a little bit on central lines, I believe, in this PowerPoint, if I remember correctly. Again, we have to teach you about central lines. Obviously, you're not going to be accessing them unless it's an emergency, and you're certainly not putting them in. So, but at least you'll have the knowledge about them when asked. So, yeah. I know I'm going through this list. We have to teach you chest tube monitoring. Yeah, central lines, Morgan lenses, blood administration, you know, all sorts of things. So, you get to teach. All right, so talking about our geriatric patients today, a lot of things happen. I mean, you're going to feel really bad about growing old by the time we're done here. But yeah, things don't really turn out so well as we get a little bit older. Our bodies obviously start to break down. You know, first of all, our skeletal system, it gets a little bit weaker. It gets a little bit more brittle. And so we start to lose, you know, a little bit of height. Our bones break a little bit easy. Our skin tears. It becomes a little bit drier. Our lung capacity, obviously, we lose the elasticity. Our cardiac output, our heart starts to kind of go ahead and, you know, we start to have hardening of the arteries and plaque building up and, you know, just a lot of great things that happen as we go ahead and grow older. Plus, we start talking about all the medical conditions that can end up happening as we get older. There's also other things that are going to affect your patients, our elderly patients, and that is the fact that they've been used to being independent all their lives. And now they come to a point that they have to rely on others to do things for them, start taking care of them. And as they grow older, their friends start to die off. They find themselves alone. Family members, a lot of times, are not always around as often. And so not only physiologically do their bodies, but mentally they start to have some issues and concerns and depression that actually starts to build up. So as we get older, our brain starts to kind of shrink a little bit within our head, more room for it to slosh around. When someone trips and falls and hits their head, you know, there's more room for that, or more chances of brain bleeds. Subdural hematomas, subarachnoid hemorrhages are the probably more likely that are going to happen. We start to see vision changes. They end up with glaucoma, cataracts. They have a more difficult time reading their prescription bottles. Now, you guys are venturing into something that's going to be pretty exciting, at least I think. I know probably not the majority in here, but mobile integrated health. Taking a look at some of these different types of assessments, realizing some of these problems that could be occurring. You know, you take a look at the vision. Can they read their prescription bottles? Are they choosing the right tablet to take in the morning? When they put all of their pills in that whole month case that they do, are they putting them in the right spots? You know, so that will be something that could affect their health. Heart circulatory, they end up with hypertension, usually secondary to atherosclerosis, and I'll forget the other one, but blood pressure, they take medication for beta blockers to go ahead and help with some of the blood pressure medication, ACE inhibitors. They've had AFib, so they're on anticoagulants, or medications that is going to cause a decrease in the clotting factors. Their cardiac output is done or decreasing, so they have to have pacemakers put in. Electrical current within the heart doesn't function like it should, so they may end up with defibrillators. Bone density, it becomes an issue. Even a slip and fall can break a femur, which the femur bone for the most part is sometimes difficult to break. Hip fractures are very common in our elderly patients. They end up with osteoporosis, kyphosis. They're very difficult then to go ahead and put on a backboard or actually stabilize the C-spine if necessary. They don't always fit the C-collars, or the C-collars don't always fit them. They end up with stenosis of the spinal column, or even compression fractures of the vertebral bodies of that spinal cord. And these are all different things that are going to affect how the patient can move. Lung-wise, they grew up in an era where smoking was cool, and they didn't wear masks when they were working in areas where there was a lot of dust particles or areas where asbestos was around. And so we see them with a lot of different lung conditions. Emphysema, or COPDs, or asthmas. The alveoli themselves do not inflate or they stiffen up, and they don't have a good chance for gas exchange. So, communicating with geriatric patients can be very difficult. When you are a physician and you work for a large corporation type hospital, we'll just use Presence for an example. Dr. Joe Dana was out there, and he is a specialist in geriatrics. And he's been told that he must see one patient every 11 minutes. That's just the way it goes for them. He says, I can't even get hi, how are you out in 11 minutes with some of these patients. He says, let alone trying to get their history from them or being able to communicate with them can be very difficult. We automatically think that we have an old person. We raise our voice 10 decibels just because of the fact that we all think they're hard of hearing. And so we have to remember, try and assess. We don't need to holler at them. We don't need to scream at them. But speaking more clearly to them, getting down on their level, and remembering how we address them. They actually grew up in the age where calling someone honey, sweetie, dear was pretty common. But, try and see how would you like them to be addressed. A lot of them were grown up in the age where they always called someone Mr. or Mrs., never by a first name. Start off with that, Mrs. Smith, how would you like me to address you today? Do you mind if I call you Gertrude or whatever her name is moving forward? Vision can be very difficult, like I said, glaucoma, the cataracts, even just the decrease in their vision. Do they use glasses? If you need them to read something or write something out, it could be very difficult to get them to do that. Trying to get them to sign your charts or your PCR tablets at the end, and they're trying to sign on that line, because that's something, technology, that they're definitely not used to. Make sure that if you are dealing with the geriatric patients and you are transporting to the hospital with some of the devices such as hearing aids, glasses, their dentures, these items are very expensive. Make sure that you have them in an area, if they're not on their person, that you give them to the hospital and they are aware of where you're putting them, because you don't want to be losing anything like that. When you start off and you get called out to our geriatric population, because we know that's the majority of the calls that we do go on, and I'm sure you've been in homes like this. They grew up in that era that you saved everything. There was always a purpose to reuse something at some point in time. Homes like this can be not only a danger to the patient, but it could be a danger to you. You don't know what's underneath there, tripping factors. But for them, it can be the tripping factors. It could also be what might be growing underneath there. Is there certain molds that cause the air to be contaminated and cause breathing problems for them? Part of the thing when we go into a home and we're really pushing our new generation of EMS to start looking at things. How many of you guys, when you go into a geriatrics home or any home, check the smoke detector when you walk by it, see if it's working. You know, notice that that banister might be a little loose. What do? Oh, the banister's loose, okay, so what? And you move on, you don't think anything of it. Do we reach out to call someone and say, hey, you know, we notice that this person does have a fall history. Their banister's loose. We've picked them up a couple times. They've got 50 feet of oxygen tubing they can trip over. There's carpets that they can trip and fall. And what can we do to go ahead and make their home a little bit safer for them? What resources in your community are available to you to get them in to help these patients so that they're not bothering you at 3 o'clock in the morning for those falls for the 4th time this week? Okay. It's winter time now, and finances can be rather tight for some of our geriatric patients. Do they have heat in their homes? Are they keep it turned down real low? Are they using space heaters? That could be unsafe. Putting a space heater next to some of this garbage could be a real fire hazard for some of them. But what can we do to go ahead and not only assess the scene size up, but assess what we could do for prevention as well? When we look at the history in the exam, we start talking to these our patients, and trying to get some history sometimes can be rather difficult. They may not understand that the doctor told them that they've got congestive heart failure and why they're on the medications that they're on. Thank you so much, I appreciate it. Why they're on the medications that they're actually on. You know, if you say, oh, do you have high blood pressure? Well, no, I don't have high blood pressure. You look at their medication, you're like, well, they're on a high blood pressure medication. Some of them think that, well, I don't have it because it's being corrected. And so looking at a patient's medications or prescription medications is going to give you some insight as to what might be going on. Now, I know not everybody is good at taking a look at someone and saying, oh, this is for that and that's for this. But if we have the opportunity to, when we can, take a look them up, start getting used to some of these medications that are pretty popular out there so we can understand what might be going on with our patients. Also know if they're not in real serious distress, trying to get to the root of the problem. Why did they call today? Did they call today because really they do have chest pain? Or did they call today because they're a little lonely? You know, I'm sure you guys have been on calls before where every shift, I was one of my old fire departments, every single shift this woman called. And she'd get out there and she always had a vague complaint. Something feels different today. I don't feel as good. As it turns out, her husband had died, and the crew that came out for her husband was the nicest set of guys, she said. And she just liked seeing them once every 3 days, so she called 911. They were able to figure this out. They made other arrangements. The guys stopped by once a day on their shift on their own time, and it made things a lot easier. It reduced the stress of the fire department from having to go on there, from taking away resources where they could have been needed other places. But remember, there's all sorts of different reasons why our geriatric patients are calling you. Some of them don't like to bother you. Oh, you know, I'm fine. It's not a big deal. I'm really sorry for calling you. And they could have something very dramatic going on. No, it just hurts a little bit in my chest. And you go ahead and run a 12 lead and they're having an MI. So to say that there's one specific model for our geriatric patients would be wrong. We have to learn to adapt with them and try and question them, talk to them, come up with really what is the true problem today. Also remember, when you're helping them, you're lifting them, their skin gets very, it's thin, it can tear very easily, and we don't want to do any more damage. So just kind of be aware of some of those concerns. Putting someone on a backboard when they're in the J position is not a good thing. You might need a C-collar. C-collars don't fit. Go back to using a horse collar instead. Some of you guys, maybe the older ones in the room, remember taking a bath blanket, rolling it up around the head, underneath the arms, helps stabilize the head to some degree. And it's not a C-collar that's going to cause discomfort to our patient. Putting them on that padded backboard, our cot, instead of putting them on a hard backboard and making them more uncomfortable. When we take a look at the vital signs of our geriatric patients, they're not the nice box area that we try and put everything into. 120/70, perfect blood pressure, right? Do they have a perfect blood pressure? Or is their normal blood pressure 150/88, and today they're at 120/70? And that actually would be our relative hypotension for them. We have a drop greater than 20 points. What is their normal? Now, hopefully a lot of these, our elderly patients like to go to blood pressure clinics. You can ask them, do you know what your normal blood pressure is? They may not know, but I bet you some of them have that little card in their purse that they're happy to share with you. When you look at their eyes, their pupils may not be as reactive because of the medications that they could be on. Cataracts, glaucoma can affect their eyes, their vision problems. We talked about skin tears. Pulse, is it regular or irregular? You know, oh, I see that you have an irregular pulse. Do you have AFib? Well, I don't know what that means. I've never heard that. My doctor tells me, and you look at their medications and you see that they're on some medication for AFib. Respiratory-wise, a lot of different reasons. One of the biggest things to remember with our elderly patients is old geezers do not become new wheezers. And what I mean by that is that at 5 o'clock in the morning, you get a call for that 88-year-old gentleman who is having difficulty breathing. You walk in and you hear him wheezing from the door. He does not have a respiratory history. He didn't develop asthma overnight. We want to make sure that we're assessing cardiac right along with that. Try and figure out what's going on today. Does he have trouble laying down and sleeping? Does he get short of breath at night? Does he have a cardiac history? Does he have peripheral edema? Maybe it's cardiac asthma today, and we need to treat it the cardiac way instead of loading him up with albuterol and Atrovent. Don't want to give him epi, for what we think if he's having problems with asthma. We also know that our elderly patients are more prone to respiratory illnesses such as pneumonia. They can go ahead at age 50 and they can have that pneumovax, good for, I believe it's 10 years. There's another one out, but I'm not sure. I haven't read a whole lot on that one. But what's their signs and symptoms? Do they sound like they have fluid in the lungs, but they haven't been feeling good for the last week? They've been running a slight fever. We don't treat them cardiac, we treat them respiratory. Again, blood pressure becomes, we know that a lot of our blood pressure medications too can have other effects on the body. Knowing what a person's normal blood pressure is very important. By the way, American Heart just came out with the new blood pressure guidelines for 2017, or 18, I'm sorry. And they've actually reduced the systolic for hypertensive crises. I brought it up at our last SOP meeting. I says this is something we're going to look at because we're trying to have a live document for our SOPs, making changes as we need to instead of all of a sudden every 5 years saying, well, here's a brand new protocol book, learn it. Making changes one at a time so it's easier for you guys to remember. But we'll see if we lower that threshold. They lowered it down to 180 from 220. But so. Some of the common emergencies, malnutrition. Now obviously it's not going to be one of those things all of a sudden that, oh, today it's an emergency because they haven't eaten. This is something over time. As a person gets older, they don't have a tendency to get up and exercise and be as active as what they normally were. So they don't eat as much. Their body is not as metabolizing as quickly. They may not have the funds to go ahead and purchase food. Where it comes back into you when you go in and you see this little old lady is 80 pounds sopping wet. Take a look at her refrigerator. How many of you guys go look at your patients' refrigerators? Yeah, you need to. There's nothing in there. It's not like some of you bachelors where all there is some beer and some cold pizza. We know that you can survive on that, but our elderly patients can't. What do they have in the refrigerator that they can continue to nourish themselves? What other resources are out there? Even though these are 911 calls and emergency calls, it's still something we want to consider when we start. You guys, the whole culture is changing on how we're assessing our patients. Take a look. We need to make sure that we're referring them, you know, Meals on Wheels, other charity solutions within your communities. Maybe they can't get to the store to get their groceries. Is there someone that can deliver them? Now, obviously, Peapod's rather expensive for them to go. They might not have the resources or the money, but is there other areas, churches that will deliver? Is there food shelters that will go ahead and deliver? Some of them might also have problems eating. The older they get, they have problems swallowing. So they're more prone for obstructive airway, foreign body airway obstructions. They'll eat a little bit. They'll wrap it up, they'll put it away. They'll eat a little bit more. And sometimes that's just not enough to sustain them. They fail to thrive. They actually start losing weight. Unplanned weight loss of greater than 5%. Now, we don't carry a scale with us. We're not going to go weigh in our patients. But, you know, some of these patients you see on a regular basis, and you notice, geez, we're getting a little bit thinner. Are you eating okay? You know, have you noticed? Ask the patients, have you noticed the weight loss? Well, I don't weigh myself. Well, is your clothes getting a little bit bigger? Okay. Other things that cause failure to thrive is the multiple infections or the multiple chronic diseases that these patients have. You know, they may be constantly sick. They're trying to deal with their medication usages. They just get to the point where family doesn't stop by. Their friends aren't around. No bridge club today. And they have that decrease in social interaction. So they sit there and they watch game shows all day. And they get more depressed as the day goes on. People who get depressed, they don't like to eat. And we see them fail to thrive this way. Yeah, getting older is really great. Yeah. You know, and here's a whole list of things too that, you know, can go wrong with our bodies. I mean, it's nothing new that we haven't talked about before. You know, the cardiac, the stroke, the diabetes, the cancer. I mean, these are all things that can cause a patient to psychologically have a decrease. Okay. A lot of the medications too, if you take a look at, they are polypharmaceutical. They are taking multiple medications at one time. Are they getting their medications mixed up? Can they afford their medications? You know, time of year where new information is coming out about your health insurance. And every year, well, my, you know, diabetes medicine isn't covered this year. What am I going to do? Even though it's covered, it's like, man, it's still $500 a month for me. Maybe I'll just take my pill every other day. Or maybe they just skip them all together because they just can't afford those couple $100s extra. Remember, a lot of them are on fixed incomes. We take a look too at some of these medications and what do they do to the body as far as our assessments. Beta blockers. You know, beta blockers are very difficult for someone who might be suffering from shock because it's not going to allow that heart rate to go up, which we normally see when we see that systemic inflammatory response. How about diuretics? Is it a potassium-sparing diuretic? Now, obviously, most of us can't look at a diuretic and say, oh, potassium-sparing, non-potassium-sparing. You know, are their electrolytes off because they're not taking a lot of fluids? You know, when we looked at our congestive heart failure protocol and Lasix, and everybody's like, why does everybody want to take Lasix out? We look at these elderly patients that are in heart failure and we think, oh, fluid in the lungs, got to get it out, give them Lasix. But a lot of these patients are already dehydrated. They don't have that good fluid intake. So going ahead and giving them Lasix when they're already dehydrated can cause further problems, electrolyte imbalances, and we need to be very cautious. Oral medications for diabetes can be an issue. What is their blood glucose? How many of them are taking opiates? No one gets opiates by their doctors anymore. Most insurance companies aren't even covering opiates anymore. But did they overtake them? Are their pupils pinpoint? You know, are they having respiratory problems? Tricycline antidepressants, hate them. They have such a narrow therapeutic threshold, and so trying to find the right dose for a patient can be very difficult. And they may not be able to go ahead and get to that doctor to make those adjustments when need be. And so if they take too many, by the way, what is the antidote for tricyclists? Anybody know? No, Gary is not your sodium bicarb. That's what you have. You know someone's on a tricyclic antidepressant. Call medical control. Ask them. Yeah, we go ahead and we look at their med box that they have sickness. Yeah, party times. And we sit there and say, I have no idea what medications. You know, I just told you to take a look at the bottles, but when you can't find the bottles and you're left with this, you may not know. It may not be helpful in getting a good history. We said a lot of these patients are on some type of blood thinner. These blood thinners, and there's a difference between the antiplatelets and the anticoagulants. And this is very important for you guys to understand what are what, because if a patient does take a fall, it could bring them up to a category 2 trauma patient. So, anticoagulants, these keep your blood from clotting or turning into solid clumps of cells that actually stick together. Antiplatelets, bottom line, I love the kindergarten term, it makes the blood slippery. You know, we take a look at what's what. Here's anticoagulants: Eliquis, Pradaxa, Xarelto, Coumadin or warfarin. This third one I haven't seen a whole lot, but that doesn't mean anything. It's just that it's one of those if you notice. Most of them are taking them because they have a history of DVTs, PEs. They have AFib. So they may end up, they've had post-surgery. They go ahead and have those central lines in place because they have cancer and they need to go ahead and have a central line. Plavix and aspirin, quercetin are antiplatelets. The anticoagulants is the ones that is going to bump a patient up to that category 2 trauma. Altered mental status. Now, I believe it's in this one. It's been a while since I've talked about that. One of the things with the altered mental status we see in our elderly is that they have some type of infection, usually a UTI, or we're looking at some type of systemic inflammatory response or septic shock when we see altered mental status in our elderly patients. Again, be alert and oriented times 3. I kind of get on my soapbox about this every single time. Usually people know who they are, they know what they're doing, they know where they are, but they're not capable of making their own medical decisions because they may be asking the same question over and over again. They may not understand what's going on. So don't always rely, oh, they're alert and oriented times 3, great, we're moving on, they can sign up. Not necessarily. Dig a little bit deeper when you're assessing these patients, okay? Yeah, and they put that on there. I just wish it would go away. So, it is our job to go ahead and figure out what's going on. We have to come up with that field diagnosis. I know I hear it all the time. We don't diagnose. Yeah, we do. We have to diagnose to some degree to determine what protocol we're going to go ahead and use. And what are we going to do to fix the problem? Because that's what we do. Our job is not just as a transport unit. Our job is to help these patients get medications on board sooner. We know that when we get to the hospital, sometimes for you guys to get a room at the hospital takes a little bit of time, right? Even though you call ahead for a reservation. Here, though, you guys can start some of these medications, and the hospital can pick it up. Most of the time, they're not going to be standing there ready to start giving the same medications or medications that the patient should have right away. This is kind of, when we talk about altered mental status, I know this is hard to see, but there's many different things that can cause it, and so many of the things you can do something about. Glucose. Give them sugar if necessary. Hypoxia, give them oxygen if they need it. Hypothermia, hyperthermia, to some degree we can. Some of the stuff we can't, like for example, let's see where to go. Infection, we're not giving antibiotics. But if we take a look at all the systemic inflammatory responses, we believe it might be sepsis, giving fluids, raising that blood pressure up if they have a decrease in blood volume. Some of the respiratory problems we can help, heart problems, arrhythmias we can do something about. So we need to start taking a look. So here's our altered mental status. Don't forget, work through the etiologies. Did they take too much of their medication? What is their blood glucose? You know, are they hypoxic? They got a pulse ox of 88%. Now, I'm hoping that if someone saw that a patient had a pulse ox of 88%, you're looking for a couple extra things. What is the pleth on your monitor? Do you have a good pleth? Does everybody know what the pleth on the monitor? Does your, first of all, does the monitor show that on your monitors? You know? Okay. If it does, take a look. You know, I've seen people go ahead and put it on there and say, oh my gosh, 74%. And you look over it and the pleth on it, it should look like nice, I don't know, kind of almost backwards shark fins, but every time they go ahead and take a breath, make sure that that's okay. Take a look and see what is their history. And you know what? Use your end title. End title is going to be great. That will give you a lot of insight as to what's going on with your patients. What can we do to fix it? Obviously, we have glucose if they have low blood glucose levels. If they're high, we can go ahead and give them fluids. If we believe they're an opiate overdose, we can give them Narcan. Take a look at what our rhythms show. Any dysrhythmias, we can go ahead and treat as necessary. Okay. So, but figure out the problem and try and fix it. Pretty standard, everybody uses this one more often. Anybody have any questions on this protocol though? So when we start dealing with patients who have altered mental status, again, we look to that scene size up, making sure that they're safe, you're safe. What could have happened? What's our nature of illness or mechanism of injury? Remember though, if you go to households and there's more than one patient that suffers from some of the same signs and symptoms, look for some type of more environmental type situation. What position is the patient? How many of you guys, when you document, you know, Evanston Fire was called to the home of so-and-so for difficulty breathing. How about we found the patient sitting in upright in bed, or we found the patient sitting on the edge of the bed in a tripod position. How you found your patients is going to be very important. It's a great thing to go ahead and document right off the beginning with your narrative. What's the temperature? Is it cold? Is it overly hot in that room? Are they having difficulty breathing? Found patient sitting on the edge of the bed. Patient was in a tripod position. Patient had visible difficulty breathing. Audible wheezes heard. That gives you a good description right off the bat of what might be going on with your patient. Or for the person who's reading your report, what could be happening. Or even 5 years down the road when you come back and you're standing in a court of law trying to defend that report and you're like, I remember now because I wrote a good description of what the scene looked like. What's the chief complaint? Again, chief complaint is what the patient states. But with our elderly patients, getting to that piece of information can be rather difficult. What is their respiratory? Is it open? Is it patent? You know, does they have respiratory sounds, stridor, wheezes, rales? Do you need to suction? Do you need to assist ventilation? If you do you need to put an OPA or an MPA in place? Do we need to intubate this patient or use the king? Now, our protocol book on our drug-assisted intubation says, attempt intubation ×1. If unsuccessful, use the king. And that's a nice statement for the most part, and I do understand that intubation is the best airway out there, so they tell us. But what if you haven't intubated in 5 years? What if this patient had a very difficult airway? How many of you would say, I'm a paramedic, I'll try the intubation, versus saying, you know what, it's been a while, this looks to be a difficult airway, I think I'm going to go with that Q tube right off the bat. Do what's in the best interest of the patient. So This is a Mallampati score. I know you guys have heard it before because I use the term every time we use respiratory, but this will tell us how difficult the airway is. You don't have to use the term. All you do is have to describe the airway. We know that in a class 1, we should be able to drive a truck right down that airway. For the most part, if your skill level is up, it's good. But if you have a class 4, you're seeing absolutely nothing when you open the mouth. That would lead a lot of us to say, well, I know no airway, no patient. It's a very difficult person to intubate. Listen, I just need to get this patient oxygen, so I'm going to take out my king. But a lot of you come back and you tell me, well, Sarah, that violates the protocol book because it says intubation times 1. You know what? Document. Chose the king airway due to a difficult intubation, due to a Mallampati score of 4. You know, whatever it is. Anybody that looks at that report is going to say, why didn't they intubate? Well, they gave me the reason why they didn't intubate, why they chose the king instead. Now, I do get the fact that you have to keep practicing to keep up on your skill, but, you know, in some situations, how dire is it that that patient needs an airway? Do what's best for your patients. What's the tidal volume? Someone who is breathing, and they're only moving at 100.
Ambulance 21, engine 21, 1110 Foster for 76, 0, female feeling held. Ambulance 21 and engine 21, 1110 Foster, 1110 Foster for 76, 0, female feeling held.
You know, someone that's breathing very shallow, remember we have that 150 mLs of dead airspace in that upper airway that's not having gas exchange. So someone who's breathing very shallow is only having air exchange in that area. And so you're going to start to see maybe end tidals rising, oxygen levels, you know, dropping. What is their oxygen status? I will tell you that just for your own knowledge again, American Heart has gone ahead and reduced the pulse oximetry levels down to 90% with the new 2018 changes. By the way, if anybody's interested, very good reading, about 400 pages, but it's pretty insightful as to why they're making changes. Got it read yet, Gary? You can borrow my copy if you'd like.
Gary was superior here.
Christmas Carol.
What's their pulse like? What is their skin temperature? Also, just remember, you guys, if someone has poor circulation, their fingertips are cold, more than likely with the pulse oximetry readings, you are going to go ahead and get false positives or inaccurate numbers. Take a look at what you're assessing and is it done properly. We always go ahead and go through the sample history. You know, that's pretty standard. Head to toe examinations. This is where we have a tendency to fall down a little bit as far as doing our assessment. We listen to someone, they say, oh, you know, sugar's low, and that's all we assess. Or they have chest pains, we give them the aspirin, the nitro, the morphine. We never do that secondary assessment. How about the fact that they have ascites in their abdominal area, or their heart is not, their output's so decreased that they have peripheral edema. Those are important things to notice and look for. Doesn't have to be a complete, you don't have to start, well, head atraumatic, eyes pearl, ears clear, mouth clear, nose clear, neck soft, no tenderness, no deformity. I mean, you don't have to go down to that extreme. But at least make sure you're doing a visual inspection. Take a look at things that could be going on. You never know what you're going to find. Sepsis, common for our elderly patients. Number one, again, we go back to the UTI, can lead to a patient developing sepsis. It does become that life threat. We've noticed through all the research that we've done that a lot of times by you guys notifying the hospital of sepsis alerts or a septic patient, they can start their process there. You guys starting process in the field can actually improve patient outcomes. And so by you guys recognizing sepsis early on, it's going to be important. You know, a lot of times we get such vague descriptions of what might be going on from our elderly. Oh, I'm a little cold. You know, I don't feel quite right today. We have to take and dive into those a little bit deeper, figure out why they're going through this. Do they have any nausea, vomiting, running to temperature, altered mental status, increased, you know, or decrease in lung sounds? Is there some source of an infection? Maybe pneumonia. Maybe it's a wound on them. They've got a decubitus ulcer. Or you notice one of their legs has a lot of cellulitis due to some scratch. Maybe their cat scratched them or something and now they're developing cellulitis. Dehydration. Are they taking enough fluids in? That will help you identify. And that's, you know, when we talk about sepsis, identifying an infection is one of the processes that we're going to take a look for. So I apologize, this one's really kind of blurry, but systemic inflammatory response. Do they have that temperature of 100.4, greater than that? Or remember, not all sepsis is got a fever. Some of it can be hypothermic, less than 96.8. What is their respiratory rate doing? Is it going up over 20? Is their heart rate going up over 90? Obviously blood pressure or blood cell count, white blood cell, we're not worried about. What's their end tidal? End tidal is really helpful in identifying sepsis or SIRS. In SIRS, the end tidal is still going to be pretty good, about 32 to 35. I mean, we're not bad off here. But as we get to septic shock, we're going to probably be down near 25. The greater the lactate levels within the body go ahead and rise, the lower our end tidal is going to be. It kind of correlates with that. But bottom line is that when we have a patient who is in septic shock, that's persistent sepsis. Their blood pressure is generally less than 90. We can start to see signs of end organ damage. That MAP reading is going to become very important, the mean arterial pressure. If you guys have the capability of switching that on your monitors to show up, it gives you some good insight. Less than 65, those end organs are not perfusing like they should. And we need to go ahead and figure out a way, give them more fluids. Remember, with sepsis, we're targeting 30 mLs per kilo for the amount of fluid for these patients. For you guys, you're not going to get that in them by the time you get to the hospital, but you definitely can go ahead and start. So in our new sepsis protocol, we did change just a couple minor things. We added or altered mental status. So you have a patient that has altered mental status. You might want to start looking here. Systolic blood pressure, less than 90. What is the MAP reading? Is that MAP reading less than 65? That's what we're looking for. You're going to start seeing MAP reading come up more in trauma, in sepsis, and it's going to be something that you guys are going to be looking for. Yes, there's a formula for those that like to do math. You can do it, but my suggestion is just change your monitor settings and have it show up on there. What's their temperature? What's their respiratory rate? Their heart rate? That's all pretty standard. Is that end tidal less than 25? So for these patients, let the hospital know. We have an idea that there might be some source of infection. We have a heart rate of 110. Respiratory rate is 24. Right now the blood pressure is consistent with 100 systolic. But MAP reading could be 70 at this point. But we know that we're leading down that sepsis, down the sepsis way. We want to make sure that we're giving fluids. And I believe it is a quiz question, so pay attention. 30 mLs per kilo is what we're targeting. The other really important point is to make sure you let the hospital staff know. Honestly, anytime you guys are administering an IV with fluids, in your report you should be documenting how much fluid you gave a patient. Specifically in this type of situation, traumas. Because the hospital is going to need to continue on where you left off. Plus, it also kind of covers your butt if the roller gets, you know, knocked undone and you end up dumping a whole liter into someone who's got heart failure. But when you left them, you'd only given them 10 cc's. So it does help. So just try to start adding that into your reports. Levophed is one of the medications that they use in the ER. Some of you guys might, the older guys might remember Levophed, leave them dead, right? We used to give this pre-hospital. But the whole goal of giving any pressor is making sure that that MAP level is greater than 65 millimeters of mercury. All right, anybody have any questions on the sepsis? All right, so central lines, as I told you, before, this is something that we're starting to educate our paramedics about. Not inserting them way out of our scope of practice, okay? But how do we access them? Can we access them now? If you had a patient that you could not get IV access, could you access this? Absolutely. Call medical control. There's a spot in the protocol book that tells you to do just that. Why do people have central lines? Well, there's a whole majority of reasons. They need to have multiple IV infusions so that they'll go ahead and just put this in line so they don't have to keep poking the patient. There's many different types of central lines out there. There's some with 3 lumens, there's some with 2 lumens, there's some with just 1. Where it's placed usually can be up in the chest area, can be as far as a PICC line, a peripheral line down in the antecubital area. And then you might even see something like these. These are little Mediports. They're give you a little bit of bump underneath the skin. And with these, there's a little stopper in the middle of them. You need to use a specific needle. It's called a Huber needle. Kind of a needle at 90 degrees, as you can kind of see here. And they'll find this through a template, and they'll insert that needle, and they can give the infusion there. These do not have a reservoir system, so it's not like they can put a bunch of medication in there at the time and then expect it to infuse over that time. That's what an intrathecal pump would be if they went that route. Usually, you can see it, a little bit of bump underneath the skin, depending on the type, but most of them are about the size of $1/4 to $1/2. But let's go back to our triple lumen up here. Which port do we use? Do we know which port do we use? We tell you guys, well, contact medical control, and they'll tell you which one to go ahead and access. Just so you're aware, when you look at these, written in very small print, so get out your cheater glasses if necessary, you will see distal, medial, or proximal words on there. And those words that are on these pigtails will actually correlate with a little hole or an outlet. And depending on what you're looking to do, what medications you're looking to give, whether you want to give a blood draw, whether you want to just infuse fluids, it's going to be which one you want. As blood kind of goes over this, okay, blood's flowing over it, you want, and sometimes like when you're doing a blood sample, you want a clean sample, something that doesn't have any medications or fluids mixed with it. So you would choose, the appropriate pigtail based on which outlet you want it to be. So for us, in an emergency situation, it probably isn't going to matter much, but just ask medical control. So how do I access these? And I'm sorry, I have brought some with me one other time and I forgot them this morning. But before you go ahead and you access these, a lot of them are heparin filled so that they don't go ahead and clot. Take a 10 cc syringe. Now, these go directly, central line. End of the catheter usually sits right in that superior vena cava. You want to keep them as sterile as possible. Make sure that when there's little clips that are going to go ahead and clamp off. Most of these nowadays are needleless, so you can access them without the needles. But if you do have to remove the cap and you have the port here, make sure you're cleaning it with an alcohol prep before you go ahead. Before you go ahead and remove any cap, make sure you're clamping them up or you're going to have blood everywhere. So clamp it. Put your 10 cc syringe on the edge after you clean it. Here's where you want to go ahead and draw off at least 5 mLs of blood, 5 to 10 mLs of blood. Gonna go ahead and make sure that there's no clots, make sure it's a patent line, draw off any heparin if necessary. And then once you do that, you can remove your syringe, clean the site again, and then you can hook up your tubing, your IV tubing to it. Or your syringe to give a medication if you're going to give a medication straight through there. Also make sure that if you are given a medication straight, that you go ahead and flush it with a 10 cc syringe.
Out of bounds, no void. Later, response to truck 22 to 30, 25 hours, 132 best hours. Out of bounds, no void. Truck 22, okay, headquarters.
Again, the big thing to remember, and it'll be one time only that you will forget to clamp it, and then after that, you're going to always remember to clamp it. Now, this could be another source of infection. As you're doing your assessment and you notice that someone has a central line, take a look at that entrance. Is it red? Is there streaks coming off of it? Is there funny colored fluids that are hanging around, green and yellow, that maybe indicate some type of infection? Make sure we're noting that. Is there any breaks? Assess these. Is there any breaks or any leaks coming from there? What do? Well, I mean, hemostats are really nice if you carry them with you, but clamp it, you know, distal to the break in the tubing. Right about here is where it's going to enter the body. This is going to be underneath the skin in the vessel, and this part's going to be out. Is that area, is there any break there? Do I need to go ahead and stop bleeding? We see bleeding. Nice occlusive dressing over the top, put some direct pressure over it. We do not want air coming into that hole. That'll go straight to the heart, create a nice little air embolus. But go ahead and make sure that if you do have any bleeding, direct pressure is all you're going to have. Do not, I repeat, do not remove it. Okay? It's going to, you know, tick off a lot of people. Make sure you're always expelling air from any syringes or IV tubing prior to any administration for them. So central lines, I know they can be scary because it's not something we deal with on a regular basis. Always have medical control to go ahead and ask in case we would ever need to access one. Generally now with the ability to do IOs, we don't really need to access them. Okay. Point of care testing. This is another area that we're starting to see out. Again, one of those topics that we're telling you about, but point of care testing is basically doing different types of blood testing right at the side of the patient's bed. Can give us information. Was it you guys that did cardiac markers years ago here? Yep. Yeah? So you guys have some general idea. They're actually putting these out now for some mobile integrated healthcare, depends on what kind of program you're running. They're using them to go out and do certain blood testing for some of the patients that they can, you know, call back to the doctor if necessary. A lot of different types of cartridges you can use. Some of those cartridges are very expensive. Usually the cardiac markers are the common ones that would be, you know, instrumental for pre-hospital, but other than that, it's just one of the different areas that we can use as an assessment tool. One other thing that's too, and they didn't put it in here, but we're going to talk briefly about is ultrasound. They are starting to go ahead and put portable ultrasound out in the field for mainly the fast. It's taking a look at mainly if there's any air or bleeding in the abdominal cavity. Taking a look at some of the heart. Is the heart pumping like it should? The training on it actually is pretty good. I know that a couple places they have for us, it's an 8-hour training they make us go before we can go ahead and use them up by where I work. But it's out there and it's being used more and more by a lot of facilities, so for a lot of services. Falls, these are common injuries. Again, when patients get older, there's a lot of different things. We saw homes that there was a lot of extra belongings. There's the 50 feet of oxygen tubing. There's the carpets. You know, patients are using walkers. They don't walk by picking up their feet, they shuffle their feet along, and it makes them trip. They get lightheaded, dizzy. They have the orthostatic hypotension. Sitting down all day, all of a sudden stand up, get lightheaded, dizzy, and they go ahead and fall. Fractures can be very common. Hitting their head, even simple standing falls can cause some significant injuries. Most of the patients that fall and end up with some type of hip fracture will end up going to a rehabilitation center after surgery if necessary. A lot of them don't make it back to their homes after that. Signs and symptoms of hip fracture, we got obvious pain and swelling to the site, shortening with external rotation, general pain when you go ahead and palpate. What is the best way that you suspect the patient is on the ground? The best way to get them onto your cot if you suspect a hip fracture. Do you guys have a scoop? Rolling them onto a backboard. Obviously we never roll them to the side of the injury, but it can be painful. Scoop stretcher or scoop backboards are really nice. You can go ahead, put them under, not the old Vernal ones that, you know, kind of pinch all the patient's fat in between them, but the nice plastic boards are real nice. You pick them up, you lift them to your cot, and you can pull that board out, and then they don't have to be on that board for the transport. Do they have some type of blood thinner? Did they strike their head? Even a patient with a hip fracture on a blood thinner can cause some serious injury. If you do have to use a backboard, you know, my suggestion is get them off it as soon as possible. How about anybody here take a sheet to stabilize the hip? Keg boards, you know, it's another use for them nowadays. Works really well. Turn them upside down. Does really well to help stabilize that hip area. You can go ahead and use. Search for crepitus. Do you feel that? Now there are different pelvic wraps or immobilizers out there, but they're quite expensive. Best thing to do is just use a sheet. Use pillows and blankets to go ahead and pad any voids, or do what you need to do to make the patient as comfortable as possible. Don't forget about pain management. It's a good idea if you have the time, give your patients some pain management before you move them, if you can. You know, that's, you know, one of the whole purposes of you guys being able to administer fentanyl IN. Now, I do understand IN fentanyl does not work as good as IV fentanyl, but at least it might take a little bit of the edge off until you get them to the ambulance where you could start an IV and administer it IV. Remember though, with our elderly patients, they have that decrease in metabolism through the kidneys or the liver, and sometimes some of that medication, if given too much, can end up causing a patient to become toxic. 1 mic per kilo is our initial dose, to a max of 100 mics per dose. We can give up to a total of 200. Now, if you're farther out and that's just not cutting it for your patient, you can always go ahead and call medical control, ask for more if you have more on your rig, or you can ask to go ahead and move on to morphine if your patient is still in such extreme pain. Here's our selective spinal immobilization. With all this being said here, it comes down to patients, or backboards are used to go ahead and move patients. You have a patient that you suspect has some type of spinal injury, or you want to stabilize that spine. That's fine. Use the backboard to move them. They do consider your cot a padded backboard. That's again why using a scoop is better to move them, because you can put that scoop stretcher right down on your cot and then remove it, and then you have them right on your back or right on your cot, where it's a lot more comfortable for our patients. You have the patient that's up walking around. When you get there and they're like, oh, yeah, my neck kind of hurts a little bit. And it's like you decide to put a seat collar on it. That's fine. You don't have to strap them and secure them to a backboard. Put them on your cot. You can let them sit up in a position of comfort and bring them into the ED with just the seat collar on if necessary. But big things to remember is patients, if they're reliable or unreliable. You know, what was the mechanism of injury? Was there alcohol involved? Okay. That's what we're really looking at when we look for spinal immobilization. Psychosocial changes, again, sensory deficits. This becomes a real concern for our elderly